Good morning. It is my pleasure to be here in the city of Pune. I must thank Dr. Sunita Chandrawalkar for inviting me. I am going to talk about poor ovarian responder. IFS, Indian Fertility Society, has come out with guidelines on poor ovarian response. This is the first guideline which is done from India. In fact, when we made this guideline, this was the first guideline all over the world. Actually, had come out with many guidelines, but they didn't come out with guidelines on poor ovarian response. So we were the first group to come out with guidelines. And we started working on the guidelines in the Fertility 2022 in December, and we collected a group of guideline development members, which were various groups, which had geneticists, embryologists, gynecologists, and infertility specialists. And this was a whole team which included consultants from all the regions of India. And Dr. C. Sankara from UK, she was our advisor for methodology, because she has been associated with various ASRM guidelines. So we wanted to work as per the ASRM guideline framework. She helped us really in maintaining that standard of guideline development group. This is the scope and key question and outcomes. We had 37 key questions which were finalized, and there were certain topics which were beyond the scope of the guideline, which were like the health economics, the IUI. They were not part of the guidelines. The PICO questions were made, 37 PICO questions, and then we made the keyword strings. We did a data search over PubMed, Medline, Cochrane, Embase, Scopus, and we had collected a lot of studies. The systemic reviews and meta-analysis were analyzed by Amsterdam 2, and randomized control trial and cohort study were analyzed by grade 2. That is the basic flow chart of our guideline. We had collected 21,935 abstracts. After the duplicates were removed, we were left with 5,826. Again, we removed 5,598 because there were studies which were not design relevant, intervention not relevant, and individual studies included in the meta-analysis, they were not relevant. So we were left with 116 full text article, and we excluded 112 because the full text article was not available, or they were only conference presentation. So 116 studies were included in this guideline. This is the milestone. We started in December 22 and we finished in 24. The collected evidence, the guideline recommendation, we defined as the quality of evidence, whether it is a high grade, moderate, or low, or very low. This is how we define our various recommendations. And the strength of recommendation is dependent on the certainty of evidence, resources required for implementation, acceptability of key stakeholders, and impact of the health equity. This is how we, based on the strength, recommendation were categorized into 4 levels. You remember this, it is either strongly recommended or conditionally recommended. It may be conditionally not recommended or strongly not recommended. So this is the interpretation of recommendation. We came out with 45 recommendations, and we had divided them, interpreted them either strongly recommended or conditionally recommended. These are the ones which are accepted. Conditionally not recommended, or conditionally or strongly not recommended, which was not recommended. This recommendation was not recommended. And the draft guidelines were prepared by March 24. We had a stakeholder review between March and May, and these were the external guideline reviews. We had a review from SR President, from Foxy President, from British Fertility Society President, from ASRM Reproductive Endocrinology Chairperson. Then we have various other authors who did their reviews, like Alberto Verelis, Paris Etta, and a lot of all the names are mentioned here. Review of the guideline was done, finished by May, and we published it on our website on June 24, and it was released in ASRM in Amsterdam in 9 July 24. That was the release of our guidelines. This guideline has been published in the International Federation of Fertility Federation, the IFFS journal, Global Reproductive Health on 8th September 25. This is the first guideline from India which has been published in this international journal. This is the recommendation. We had 37 PICO questions and 45 recommendations were done. The evidence-based recommendation, the summary, the pre-stimulation management, the evidence-based recommendation for use of AMH as a biomarker for predicting poor ovarian response, assessment of enterofollicular count, these are strongly recommended. Then there are interventions which are not recommended for POR in clinical practice, like routine genetic polymorphism, routine pre-treatment estrogen in luteal phase is a conditionally not recommended. Oral contraceptive pill is not recommended strongly. Routine use of gonadotropin releasing hormone and antagonist delayed start protocol is conditionally not recommended. Pre-treatment with antioxidant is not recommended in poor responder. This is also conditionally not recommended. And the lack of evidence on recommended specific lifestyle-related intervention is strongly not recommended. So in this, there are three recommendations which are conditionally not recommended. Probably we can find more evidence and then they might be accepted later on. That is the use of estrogen in the luteal phase. Most of us think that using estrogen in the luteal phase gives us a better chance, but it is conditionally not recommended because if you look at the analysis, the rationale, there is no much change in the pregnancy and live birth rate. That is important because we cannot find, we fail to find conclusively the change in the live birth rate or pregnancy rate. That is why it is conditionally not recommended. Insufficient evidence to make a recommendation and you need further research. This is like recommendation for routine immunological testing. It is further research and insufficient data to make a recommendation for alternative medicine-based therapy for poor responder. Also need further research. Evidence-based recommendation for clinical practice. The antagonist protocol and long agonist protocol are equally recommended. The mild stimulation is also equally strongly recommended. Mild stimulation with oral letrozole in combination with low-dose gonadotropin is also strongly recommended. And mild stimulation with oral clomiphene is strongly recommended. The decision to use only clomiphene in poor responder is a GPP, good practice point. There is no recommendation that whether it is strongly recommended. It is good practice point that you can use oral clomiphene alone as a mild stimulation protocol. Interventions which are not recommended in pure practice, these are the agonist failure protocol, is strongly not recommended. Dual stimulation protocol is also strongly not recommended. I'll give details about this recommendation. The luteal phase stimulation is not recommended. The modalities of natural cycle protocol is not recommended, modified natural cycle protocol. The progesterone prime protocol, stimulation protocol is also strongly not recommended. We'll talk about it. And short agonist protocol is also not recommended. It is conditionally not recommended. The dual stimulation, most of us think that dual stimulation is one which can help us in poor responder. And our recommendation that it may yield additional leukocyte and higher number of viable embryo for transfer, reducing the dropout compared to conventional stimulation protocol. However, it does not improve ongoing pregnancy rate or live birth rate when compared to conventional stimulation. And in this, when we received this external review from Alberto Varelis, he was more this thing that he should be doing more of a dual stimulation. But our guidelines development group met, discussed it, and we decided that we need to have robust evidence to support clinical decision. And despite limitations, some studies, our randomized controlled trial remain the most valuable guideline information for the guideline. And there is still not enough randomized controlled trial for dual stimulation. And due to the absence of randomized controlled trial or dual stimulation or two consecutive stimulation, in the same patient with mandatory postponement of embryo transfer and dual stimulation is not recommended as the current point. Maybe in future we might change this recommendation. The biostimulation, the randomized controlled trial of using two stimulation consecutively, and this based on the number of total and mature oocyte retrieved in women with poor ovarian responder, there is no benefit of dual stimulation versus two consecutive stimulation. And we had another paper from Polizos in 24, and he did a fresh embryo transfer following dual stimulation, but he also concluded that dual stimulation with fresh transfer is as good as a single stimulation in a low prognosis patient. The decision for performing dual stimulation should be evaluated with caution, considering that while this may improve embryo transfer rate and pregnancy outcome is still unclear, and that is why we have not recommended dual stimulation. It has not been recommended. The progesterone prime stimulation also, similarly, it has been written that it prevents premature LSH, does not significantly differ the gonadotropin antagonist in terms of average number of oocyte viable embryos or live birth rate. The protocol mandate, once you use progesterone prime, you have to do embryo freezing, which require additional resources and further embryo transfer. That is why we are not recommended as we are not recommending for progesterone prime stimulation. The evidence-based recommendation for clinical practice, the human menopausal gonadotropin or recombinant FHS equally recommended. These are all strongly recommended. Mid-follicular addition of HMG is conditionally recommended. Early or mid-follicular addition of recombinant LH is also conditionally recommended. The choreofollicular alpha is strongly recommended. Choreofollicular alpha with HMG is also equally recommended. Intervention not recommended in clinical practice. The use of urinary FHS is not recommended, is conditionally not recommended. Increasing the dose of gonadotropin is not recommended. There is no point in increasing the dose. Recombinant follicular stimulation monotherapy is not recommended over recombinant LH. Intervention not recommended, again, the adjuvant therapies. Like adjuvant dose use of growth hormone is strongly not recommended. Adjuvant use of testosterone in ovarian stimulation is conditionally not recommended. Adjuvant use of DHEAS is strongly not recommended. Use of coenzyme Q10 is strongly not recommended. The use of testosterone in poor ovarian response is conditionally not recommended. I presented this paper in ASRM 2 years back, and the speaker before me was Polizos. He had also presented the paper, but he used half the dose than what we were using. And at the end of the discussion, it was decided that he is going to do another meta-analysis on testosterone, and he has included our study also in the meta-analysis. Till now, it is conditionally not recommended, but maybe the issue might change in future. The use of CoQ10 is also strongly not recommended. Despite the potential benefit of CoQ10 in reproductive outcome, the available evidence is it is not established adjuvant, and there is no change in the clinical pregnancy rate or live birth rate. We had analyzed this network meta-analysis, which was analyzed, which was included in our recommendation. 19 trials of longer criteria, 2,677 women were analyzed, and the result of the network meta-analysis was that addition of DHEAS, CoQ10 and growth hormone showed better clinical outcome only in terms of achieving pregnancy and a low dose of gonadotropin. That the dose of gonadotropin is reduced, and there might be some benefit in achieving the pregnancy. That is the result of the network meta-analysis. Insufficient evidence to make recommendation. Further research needed is in cases of use of glucocorticoids. These are further research. Insufficient evidence to make a recommendation. Further research. There is insufficient evidence to make a recommendation for addition of routine hormone assessment like estrogen, progesterone, luteinizing hormone. This is all conditionally recommended. It needs further research. Intervention not recommended. To cycle cancellation, you have to convert to IUI. It is conditionally not recommended. You don't convert it to IUI. And intervention not recommended. Criteria for treating final oocyte. You can use dual trigger. It is conditionally not recommended. And routine elective freeze-all is also strongly not recommended. Intervention not recommended for clinical practice. Routine use of follicle flushing, we don't recommend it. Routine use of ICSI over IVF is strongly not recommended. Routine pre-implantation genetic testing is strongly not recommended. Routine in vitro maturation of oocyte is also not recommended. Other not recommended in clinical practice is ovarian rejuvenation techniques like intra-ovarian platelet plasma is not strongly not recommended. Intra-ovarian stem cell therapy is not strongly not recommended. In vitro activation of ovarian tissue is also strongly not recommended. We go for this intra-ovarian PRP. We included this study in our recommendation. This was the first randomized control trial published in Fertility Society 2024 by Amsterdam. They had included 83 patients, 41 patients received PRP, 42 patients didn't receive PRP, and they found out there are no significant difference in the number of M2 oocyte retrieved or in the PRP group, the blastocyst or euplasmocyst. They didn't find any difference. This is first randomized controlled trial. I know many of my colleagues, they are publishing their result of intra-ovarian PRP. They may use 2 cases, 3 cases, 10 cases, but none of them have done a randomized controlled trial. We are still waiting for more randomized controlled trial to see whether intra-ovarian PRP has any benefit or not. Thank you very much. This is my GDG group. We have worked very hard for almost 2 years. Thank you, all the GDG members. Thank you.
Thank Dr. Nayar for sharing the recent guidelines. I'm sure poor responder, the section needs to be counseled very well beforehand because of these new guidelines are there, and I think it will be very beneficial. Thank you so much, sir.
Thank you, ma'am.
Thank you so much. Can you have a picture with the chairperson as well as the speaker? Moving along.